Добрый вечер, дорогие участники встреч без границ. Меня зовут Шихер Анна, я заместитель руководителя факультета психологии на факультете психологии в Высшей школе «Среда, обучения». Я рада вас приветствовать на встречах, которые уже становятся нашей традицией. Во вторник в 7 часов вечера по Москве мы встречаемся с международными экспертами для того, чтобы в который раз доказать, что в нашем современном мире дистанционный формат открывает безграничные возможности. И сегодня, в том числе, наш факультет психологии организует лекцию с сертифицированным поведенческим аналитиком Майклом Кэмероном. Сегодня темой нашей встречи будет изучение того, как с научной точки зрения люди принимают решения. Сегодня поговорим о разных аспектах принятия решения. По регламенту сегодняшней встречи 1:15 идет основной материал нашего прекрасного лектора. После этого выделяется 15 минут на ваши вопросы. На протяжении всей сегодняшней встречи я буду с вами здесь находиться на площадке, поэтому свои вопросы, какие-то комментарии вы можете писать в чате. Все вопросы будут сохранены, и в дальнейшем, когда для этого будет выделено отдельное время, мы зададим эти вопросы, и у вас будет возможность получить развернутый ответ. Кроме этого, для вас подготовили ряд дополнительных материалов, которые вы в конце сможете также получить ссылкой уже записью. Сегодняшнее мероприятие полностью проходит синхронным переводом с английского на русский. К сожалению, на данный момент нет технической возможности сделать две дорожки, но в записи вы сможете получить запись и с английской, и с русской дорожкой. Ну, на этом я больше не буду забирать у вас время от сегодняшнего занятия. Встретимся с вами в конце сегодняшнего мероприятия. И интереснейшей вам лекции я еще раз представляю сегодняшнего нашего спикера Майкл Джеймс Кэмерон, сертифицированный поведенческий аналитик. Успешной лекции. До встречи в конце.
Thank you so much for the invitation. And once again, I'm Michael Cameron from the University of Southern California in California. My wife speaks fluent Russian, and she's always trying to get me to learn Russian. So what she does is that she has me watch Chibarashka cartoons, and that's been her attempt to teach me Russian. And I am sad to say I have not been successful, and I apologize here in this room for doing the presentation in English and not in your native language. But I'm thrilled to be here. I'm going to share my screen at this point, and I will continue on with just a brief overview of the agenda. As it's been mentioned, one of the things that was of interest when I received the invitation to present to all of you was a decision-making process, a clinical decision-making process. So what I'll be doing during the next hour and 15 minutes or so is touching on 5 essential decision points that a psychologist has to manage and has to consider as they're providing clinical treatment to an individual. And when I say clinical treatment, it doesn't matter if you're working with an individual with a psychiatric disturbance, for example, such as depression or bipolar disorder or unipolar disorder or obsessive compulsive disorder, or whether you're working with an individual, for example, with autism spectrum disorder, or whether you're working in the context of an organizational setting and you're providing clinical support from an organizational health standpoint. So I'm going to touch on decision-making, but I'm going to anchor it to case studies and case conversation just to make sure that the points get across thoroughly. So I'm going to touch on, first and foremost, outcome measures and how to identify them. And I'm going to talk about cultural considerations as well when engaged in the process of clinical support. I'm also going to discuss the behavior change model and what everybody can expect with respect to the process for behavior change. From there, I'm going to touch on multifactorial causation, looking at the reasons for the onset of a problem, again, whether it be psychiatric in nature or some other form of psychological condition, we have to consider multiple reasons for the onset. Then finally, I'll conclude with the discussion about interdisciplinary collaboration and what's referred to as coordination of care. And then finally, the relevance and importance of what's referred to as evidence-based practices and clinical decisions and decision support systems as well. So that is our agenda. I just want to give you a bit of a preview on everything that I'll be discussing. Point number one, in terms of a decision, and this is one that is always critically important to me, is that if I take on the responsibility to provide some kind of intervention or support to an individual from a psychological standpoint, my first question is this: what am I trying to achieve? What is the outcome? What is it that I can produce for an outcome that results in a value to the recipient of the service, and a sense that what I did for them from a psychological standpoint actually mattered? So that's the first decision point that has to be considered. One of the things I want to bring your attention to is what's referred to as the International Consortium for Health Outcome Measures. The acronym is what's referred to as ICHOM, again, International Consortium for Health Outcome Measures. The implication of this information is this: when you're making a decision to intervene, it could be a person with depression, for example. It could be a person with Alzheimer's disease. It could be a person with some other health condition, for example, diabetes. There is what's referred to as a minimum clinical data set. And the abbreviation for that is MCDS, Minimum Clinical Data Set. And this is internationally agreed upon outcomes for a condition, like a psychological condition. So one of the things I've done for you, just to give you some substance in terms of this information, is that I took the ICHOM minimum clinical data set for depression, and I have it displayed here on the screen in a wheel for your consideration. I want to bring your attention to the outer part of the wheel. What you'll see on the top right is symptom burden. So from an outcome standpoint, we have a responsibility to measure symptom burden and then demonstrate that we're making progress with respect to the person's symptom burden. Okay, now if we swing down on this dial to the lower right, we're interested in the person's functioning. And I'm going to get into the exact details on this in a moment, but I'm just giving you a broad overview. We go from symptom burden to functioning, and then swinging up to the left of the dial, we got recovery speed and health sustainability. So not only do we want to make progress with the individual, we want to make sure that that progress sticks, that the person benefits from it on a long-term basis. And then there's some other considerations. Okay, now let me just move into the details. Here's the implication once again. We have minimum clinical data sets. It's an important decision to make. We've decided to treat an individual or to guide somebody's life, which is an enormous responsibility. We have to be guided by the outcomes that we're looking to achieve. It's ICHOM, the International Consortium for Health Outcome Measures, that produces and publishes this. And the reason I bring it to you is because I have enormous respect for the international aspect of this. It is cutting across cultures, across communities, across worlds, and it is avoiding a bias. So they do this to make sure that nothing is American-centric or just based on the opinions and the thoughts of people in the United States or the Western culture, for example. So everybody in this room has somebody in their life that struggles with depression. And it may not be somebody in your life, it may be you. You may fall into this category. None of us are immune to these kinds of conditions. We don't exclude ourselves from it. So on the top of the wheel, one of the things that we're responsible for evaluating is the symptoms of burden. I want to bring your eye to the numbers on this dial. So right after symptoms of depression, you'll see a number. The reason that number is there is because it will be crosswalked and cross-referenced over to a measurement strategy, which I'm going to show you in a moment. So whenever we say we need to improve something, we're also getting a recommendation from ICHOM in terms of tools to use to demonstrate that improvement actually occurred. So we want to develop an intervention that results in a reduction of the symptoms of depression. However, there's also, with depression, oftentimes co-occurring conditions. And for depression, a co-occurring condition is often anxiety. So if a person is struggling with both anxiety and depression, then we want to have a measurement tool in place for anxiety as well. Once again, let me bring your eye to those numbers. You'll see number 2 and 3, because that's going to be cross-referenced to a measurement scale for evaluating anxiety levels. Now, the other thing that's important when managing or providing support to an individual with depression is their physical functioning. For a person with depression, they often lapse into a state of inactivity. They many times disconnect from physical activity, physical movement. They become sedentary, stationary, and a lot of movement does not occur. And I'm not making big generalizations here. I'm not saying everybody that suffers from depression falls into this category, but it's on this wheel because many people will disconnect from physical activity within a depression state. So for that reason, one of the critical things to measure is physical functioning. You know, if I'm really making improvement with this individual, then I'm reducing their symptoms of depression, I'm reducing their symptoms of anxiety, and I got this person actively engaged. And the type of engagement will completely depend on their preference. You know, the individual could be somebody that enjoys hiking or walking or boating. It's not for us to decide what that looks like. It's for the individual to tell us what good, healthy physical functioning is for them, and for us to use that as a measure of their progress. So physical functioning is a critically important component of all this. What goes along with that is work functioning. Once again, somebody in this room, either you yourself or somebody that you know well, has struggled with depression. And when they move into a depressed state, they can also begin compromising their employment. They may not go to work. They may stay home for long periods of time. They may disengage, even from an employment standpoint. Or if the person's self-employed, then they just stop the activity and their vocation and their livelihood. So we have to measure as well work functioning capability. Let me just give you a quick story on this one. I recently reviewed a manuscript for publication that came out of Japan, out of Tokyo. And the author, who's a psychiatrist, identified an intervention for a woman in her 40s with depression. And this individual's depression really was driven by a skin disease that she had. So what happened is that she terminated social contact, and she also terminated and reduced her work activity as well, which became enormously problematic for her because she relied on income. She was self-supporting, and she relied on that to completely support herself. So to his credit, he included a measure on work functioning and showed that after he treated her not only did she re-engage from a social standpoint, but she re-engaged in terms of physical functioning, physical activity, and she returned to work on a full-time basis. That is credible in terms of an outcome. And one of the things I can't stress enough in this room today is that as a first decision, getting clarity in terms of what you're trying to achieve. And we do have a really good model that is referred to as a minimum clinical data set in order to guide us in terms of our achievements and what we're trying to do. Continuing on the wheel, we look at social functioning. We also look at time to recovery. What that means is that for a person with depression, especially for a person, for example, with bipolar disorder, they may move into a depressed state. And a good measure of successful treatment is how rapidly that person goes from the depressed state back to normal functioning or homeostasis. So the time to recovery is a critical measure in terms of the success of your treatment. And then we look at the recurrence of the disease state, in this case, depression. You know, how many bouts of depression does an individual have during the course of the year? How many episodes would they have during the course of the year? And then finally, on the top of the wheel, we look at medication, because many individuals with depression will be treated not only from a therapeutic standpoint, but also possibly from a pharmacological standpoint. So some kind of medication enters into the picture. When that happens, you've got to make sure that the person is not experiencing side effects of that medication that would result in their desire to stop taking the medication, discontinue it, or to be inconsistent with it. So from a big picture standpoint, if you just step back for a moment and take a look at this entire wheel, what you're looking at is quality of life outcomes. So it's not good enough to just put a focus on one measure. What is really needed is a focus on multiple measures so that you're not only changing specific things in the individual, but you're also improving on a simultaneous basis the individual's quality of life. And I think everybody in this room would agree that if you're re-engaged physically, you are re-engaged from an employment standpoint. You're connected again socially with your family, friends, your children, and that you have minimal side effects from any medication that you may be on. That entire picture leads to a claim, and a legitimate claim, that the intervention put in place was effective. So once again, just to repeat myself, there are minimum clinical data sets that are available to you already. Many of them have been developed by ICHOM, International Consortium for Health Outcome Measures. And this is the first decision that you have to make, is what am I trying to achieve? I've got the responsibility, the serious responsibility of guiding another soul and their life. And what am I going to use as a basis for indicating I've actually made progress with that individual? And what is that person going to use as a basis for understanding their own progress as well? Remember the numbers on that wheel? They correspond to these assessment tools and evaluation tools. So here in the United States, we got the Beck Depression Inventory. That can be a measure. We got the Inventory of Depressive Symptomology, which can be a measure. You get the idea. And then we also have physician administered measures such as the Hamilton Rating Scale for depression. So every one of those numbers that you saw gets crosswalked over to an assessment tool so that you can evaluate the person's symptom burden. And this is an important aspect of psychological treatment because we want standardized, available, commercially available tools to us, tools that have been validated as being effective. And we want to use those tools for the purpose of evaluating progress that we're making. The other thing I want to bring to your attention is this article, and it's a framework for standardized methodology for developing minimum clinical data sets. So imagine that you have a case or you're treating some condition where a minimum clinical data set is not available to you. Maybe ICHOM has not published one on this particular psychological condition or disease state. This particular article is a guide in terms of identifying your own minimum clinical data set in order to truly evaluate and credibly evaluate the outcome that you're producing with an individual. Every article that I mentioned today within the course of my presentation, I've sent over to your university. So if anybody in this room is interested, you'll have access to it. Of course, it's in English, and I apologize for that. But I do like to make sure that everything that I talk about gets connected to the professional literature for individuals. Okay. Now, those measures that I just showed you for depression are what's referred to as a macro measure, otherwise thought of as a big picture measure. And you know as well as I do that you can be working with an individual with some kind of psychological condition. You may even be making an impact on that individual, but that impact may not necessarily show up on the assessment tool, because you may do an evaluation and then a reevaluation 6 months later, and you may not be picking up the progress of the individual. For that reason, we also use individualized tracking tools. So what you're looking at on the screen here is a tool for an individual with bipolar disorder. And I'm going to bring your eye to the center of the upper portion of this tracker where it says stable mood. This requires you as an interventionist and as a clinician to define what stability is for the individual that you're treating. There's no generic definition, because if I go around this room and I called on you one by one and I said, when you are stable, when you have good evenness, when you have homeostasis, what is your presentation? What do you look like under those conditions? So my point here is that each one of these areas gets described based specifically on the individual that you're treating. So this allows you to score daily where the person is with respect to their mood variation. So if you go upward, you can see that a person can move from stability to being mildly manic, or what's referred to as hypomanic, to somewhat manic, right up into an extremely manic stage. And then if you go downward, mildly depressed, somewhat depressed, you get the idea. You can also record the number of hours the person slept and the number of uninterrupted hours they slept, and what supports they have in place and what medication then they may be using as well. And here's a second page of the form. It just allows you to indicate whether there's physical illness and whether the physical illness may co-occur with variation in mood, or menstrual cycle and whether that's co-occurring with mood variation, meals and whether they're consistent or not. You get the idea. So I just want to bring to your attention that in addition to the large measures, what's referred to as a macro measure, where we use these standardized tools, you can also get micro data, very individualized data, because many times changes that are favorable, changes that are positive, will show up on this type of recording system before it shows up on your standardized assessment tool. So decision number one, what outcome measures am I identifying? What is my beacon? What is my light? What is my guide in terms of claiming that I'm making progress with an individual. You have at your disposal an entire battery of measurement tools that are commercially available that can be used. And you also have these individualized tools that can be customized for a person, all for the purpose of evaluating your impact clinically. That is decision number one. For me, in everything that I do, whether I'm working with an individual with some psychological condition, or whether I'm intervening at a large scale, like from the standpoint of organizational intervention, I always start by asking the question, and I always make the decision, what tools and what measurement systems am I going to use? Once again, I want to emphasize that the answer that you generate is going to be dependent on the psychological condition or the circumstances that you're looking to address. But that is decision point number one. Okay, let's transition at this point. Decision number two has to do with cultural considerations that you cannot bypass or turn a blind eye toward culture and the individual's unique circumstances from a cultural standpoint. That has to factor into treatment as well. I just had accepted a couple of weeks ago, this is my recent manuscript. It's entitled Culture and Language Inclusion in the Practice of Behavior Analysis, and it's a call to action. And I wrote this paper with my colleagues because I'm really concerned about the disregard for cultural factors when it comes to clinical treatment. So this will appear in the Journal of Behavior Analysis and Practice within the next month. From a cultural standpoint, one of the things that we have to understand is that a person's belief system and the opinions of other people in their environment, in their culture, is going to matter. It's going to make a difference in terms of whether or not that clinical intervention that you're trying to develop will actually be supported or not. One of the things that I've done in my career is that I've worked with individuals with addictions, meth addiction, for example, heroin addiction as well. And one of the things that I always had to consider is that whether or not the intervention that I use, what I want that meth addict to do, or what I want that heroin user to do, will that behavior that I am generating in that individual be accepted in the drug culture? So this is a big deal. One of the things that I can't emphasize enough is that in clinical treatment, you have to get out of your own head in terms of the way you think and put yourself in the world of the individual that is the recipient of services. So it is your responsibility, in my opinion, to understand that world as well as you can. Understand the drug culture world. Or if you're working with an individual that's a victim of domestic violence, for example, understand that world. Understand their decision-making and the factors that come into play, because that information will inform your clinical intervention and will guide your clinical intervention. When interventions fail, oftentimes, is because culture is not taken into consideration, and the likelihood of acceptance of an intervention is not considered, and whether or not the cultural context will actually support it, that is often not considered. So culture matters. And when I talk about culture, I can be discussing ethnicity, I could talk about creed, I could talk about religion, I could talk about drug culture or alcoholism or domestic violence. All of those are cultures that generate and have to be considered in the context of clinical treatment. One example I'll give here is dance culture. So not all people who are dancers struggle with eating disorders, but many people in dance culture will struggle with some form of eating disorder in their lives, whether that be anorexia nervosa or bulimia nervosa will depend on the individual. So in the terms of culture, one of the things that we know is that anorexia is characterized by persistent restriction of food intake. It has a couple of different forms. There's anorexia that's associated with binge eating and then purging. And then other individuals will simply intermittently binge and use self-induced vomiting to avoid weight gain. And from a progress standpoint, about 50-60% of individuals with anorexia recover, 20 to 30% partially, another 10% to 20% remain chronically impacted. The other thing that's important to know is that the mortality rate is 12 times higher than the death rate for all causes of death for females between 15 and 24. Okay, so if we know this, and again, this is just a case study, I'm just talking about cultural aspects and the things that you have to consider and the decisions that you have to make with respect to culture. If you're treating an individual with anorexia and you know that they are in the dance culture, then one of the things that's common in the dance culture is the use of diuretics. These are medications that produce and allow you to void more excessively than you ordinarily would. And it's common to use antidepressants as well. Both of these will cause weight loss and allow an individual to maintain a very low body weight. So the question becomes this: if you're treating an individual, you may not be a dancer yourself, and you may not even be part of the dance culture, but if you know that you're treating an individual with anorexia or with bulimia, and that culture supports the use of diuretics and the use of antidepressants for the purpose of reducing body weight or remaining at a low body weight, then your intervention is in competition with those cultural factors. And if you're not taking those things into consideration, if that doesn't enter into the picture in terms of your comprehensive treatment, then you'd be remiss. You'd be avoiding something that is really going to partially determine the success of your treatment. So my take-home point is this: culture matters. Understanding the culture a person is operating within. From the standpoint of your knowledge, you will have to extend beyond your scope of knowledge and understanding, because you may treat an individual from a culture you have no familiarity with at all, but it does require an inquiry. It requires evaluation of those cultural circumstances so you can optimize the recommendations that you make and the intervention that you put in place. Okay, to summarize so far, decision one: what are your outcomes? What do you plan on using to make claims that you're actually making progress with an individual? What are you using for measures that actually allows the person to self-evaluate whether they're making progress? That's a decision point. And we've got some really good supports in place to make those decisions, and ICHOM is just one of them. Decision point number two: are there cultural considerations here? Is there something I need to know about this person's unique circumstances that will inform my intervention and inform my thinking about how I'm going to support this individual? Are the cultural factors ethnic in nature? Is it religiously driven? Is it driven by creed? Is it driven by subculture like alcoholism, substance abuse, drug abuse, dance culture? All these things have to be answered in order for you to generate the best treatment option that you can for an individual. I did do some research in preparation for my meeting with you today. I did some research in different aspects of anorexia. And here's an article on eating disorders and body image, and how individuals from both Japan and Russia within college, university settings, actually think about these things. Again, this is my way of getting out of my world and entering into the world of the literature and gaining an understanding of something that I have no awareness about. And the way I do that is by my own diligent inquiry to make sure that I'm fully informed and that the treatment that I recommend is influenced by these very, very important factors. So once again, at the beginning of this presentation, I promised you that I would link everything back to the literature. It's my way of keeping things credible and giving you resources as well for the purpose of your own thinking. Okay, the third decision that I make has to do with the behavior change process, because everybody goes through their own process in terms of behavior change. And what I have to determine is where an individual is with respect to their readiness and their preparation for some kind of change. So again, doesn't matter if I'm talking about a person with bipolar disorder, depression, doesn't matter if I'm talking about a person with anorexia or bulimia or binge eating disorder. Doesn't matter if I'm talking about a person that may be the victim of domestic violence. I have to understand first and foremost what their readiness is and whether they're prepared for behavior change. This is what's referred to as models of behavior change. And I want to bring your attention to one important piece. And these behavior change models, they're available to you. And they've received increased attention, especially over the last decade, I would say, especially in the areas of health, education, criminology, energy conservation as well, and international development. You think about this from a criminology standpoint. What is this person's readiness to shift and change their criminal activity? From an energy conservation standpoint, what is this community's readiness to shift and change so conservation becomes important to them? Or even from an international development standpoint, what is the culture's preparedness and readiness to begin improving relationships with other countries? You know, I'm sitting here on the other side of the world, you know, coming from a political climate that has been adversarial for a number of years. And the question becomes, you know, what is our readiness to begin reaching out and repairing relationships with other countries in the world? What is the preparation? What is the readiness for that? This is what's referred to as models of behavior change. And I'm going to describe one of them to you because it's the one I use the most. However, these others are available to you. There's social learning and cognitive theory. There's theory of reasoned action, theory of planned behavior, health action process approach, and then the Fogg behavior model. That's named after a person out of Stanford, B.J. Fogg behavior model. The model that I use the most to make a decision about where a person is in terms of their personal readiness to change is what's referred to as the trans-theoretical model. It's also called the stages of change model. And I'm going to describe a couple of aspects to you, and you're going to get the idea rapidly in terms of why I use it. But once again, staying true to my commitment to you, I link it back to the literature. This is a seminal publication, an important publication by Dr. James Pachaska, who's out of the University of Rhode Island in the United States. And the title of this paper is The Trans-Theoretical Model of Health Behavior Change. Okay, before I get into this, I want you to think about this for a minute. Think about somebody in your life who struggles with alcohol use, who may struggle with drug use, who may struggle with an eating disorder, who may struggle with a medical condition that they're not attending to. I am certain that there are people in this room that have either experienced it themselves personally or have somebody in your life that has fell into this category where they don't want to talk about it. It's not up for discussion. The alcohol use, the drinking is off the table. There's no discussion. The drug use, the drug abuse, the substance abuse, off the table, not for discussion. The domestic violence, not to be discussed. Everybody in this room today knows somebody, perhaps you yourself, that has fallen into this category. That's why this trans-theoretical model is so critically important, because one of the things that we know is that when we go through a behavior change process, it occurs many times in steps. So I'm just going to briefly describe the steps that an individual will go through in terms of the behavior change process. There is what's referred to as a pre-contemplation stage. So I'm looking at my table here, and on the top of the table, you got the stage in this top ribbon. You got the stage, and then to the right, the definition, and then examples, and then potential strategies to use if the individual is in this category. So people in the pre-contemplation stage are individuals that will not talk about the condition. They will not talk about the alcoholism. They will not talk about the drug use. They will not talk about the domestic violence. They will not talk about their medical condition. It is off the table. When somebody is there, it's what's referred to as the pre-contemplation stage. If you take anything out of this lecture today, anything, I would like you to take this from the lecture. Evaluating where a person is in terms of their readiness for behavior change is going to drive the likelihood of your treatment success. If you try to skip over this process of understanding where the individual is, then you will put them in a state where you'll get non-adherence, resistance to treatment, or you may get short-term cooperation only for the person to default back to their old ways. The second thing I want you to take away from this conversation is that there are times when a person's in a pre-contemplation stage where you don't have the luxury of working with them and giving them options in terms of how their treatment will progress. The person may be in an emergency situation. The person has overdosed. The person has become so intoxicated that they're having blackouts. There may be occasions where individuals are supported quickly and in an emergency situation, and it doesn't result in their input. You had to take action. Those are certainly cases that we have to consider. This model is designed for working with an individual in a progressive manner and not in a manner that is expeditious or fast acting. So a person in a pre-contemplation stage, back to the grid, is somebody that won't talk about the issue. So there's a very specific way of working with that type of individual, and that is bringing your eye over to the right of the grid, increasing awareness of the need for change. And that isn't necessarily even directed to them specifically. It can be more directed to the population of individuals that may be abusing alcohol, the population of individuals that may be abusing drugs. But it's a way of entering into conversation for an individual that is reluctant or resistant or lacks awareness around the issue. The next stage is what's referred to as contemplation, and it works like this. Okay, I'll talk about it, but I'm not going to do anything about it. So yes, I'm willing to talk to you about the alcohol use, but don't impose or expect that I'm making any shift or change. That's not happening right now. So the individual may be willing to discuss, and they may even commit to doing something in the next few months or the next 6 months, but they're not going to do something now. But that is progress, getting a person from pre-contemplation. And I want you to think about this again. Think about somebody in your own life that was completely resistant in terms of talking about something. And wasn't it remarkable when you finally got the person to acknowledge that there is an issue and conversation began to occur? It is life altering for you to be on the receiving end to finally make that movement. So the impact and the relevance of this shift cannot be underestimated because it is a big shift for an individual. The person in the preparation phase, I'm bringing your eye down on the grid here to preparation. This means the person's putting things in place in order to make something happen. This is also what's referred to as a process goal, that for any change to occur, we do go through a process. So, for example, let's say a person's struggling with body weight. Maybe they have excess body weight. They've agreed that they're acknowledging that there's an issue, so they've gone from pre-contemplation to contemplation. In preparation, maybe they've made an appointment with a nutritionist. Maybe they've made arrangements to begin going to the gym on a routine basis, or walking or hiking on a routine basis, and they're putting plans in place. That's what's referred to as preparation. Many times people become relieved just as a result of preparation. How many people in this room, be honest, have decided that the excess body weight that you have, you're going to lose it, but you're going to start next Monday? Not today, but next week. So you've gone into contemplation, to preparation. You may even put things in place, but it's in the future as well. So the preparation stage is relevant. It's important to get that shift because the person is beginning to take steps and actions to actually shift and make a change. The final two stages include an action stage where the person is now engaged in the behavior change activity. And then, of course, the maintenance stage whereby the person is sustaining their impact. Smoking cessation would be a nice example here. A person that's moved from preparation, whereby they've stopped buying cigarettes, for example, to action, where they're actually refraining, stopping smoking. And now they're successful for 6 months, 8 months, 9 months, a year, and they're in maintenance. So they're feeling pretty good about their progress. Okay. What I want you to know about the trans-theoretical model is that it's not linear. It is not lockstep. A person can go from pre-contemplation to contemplation and preparation and then relapse and then go back to a pre-contemplation stage where they're not talking about something. So it's not lockstep. And just because a person achieves some level does not necessarily mean that they're going to stay there. Why am I telling you all of this? It's because of this. The decision that you have to make and what you have to consider is where this individual is, if it's clinical intervention, where the person is in terms of their readiness for change. Because if you leapfrog over one of these stages, you try to take a person from pre-contemplation to action, then you'll get resistance from the individual. This is like somebody telling you that you need to do a little bit more in terms of physical fitness, and they took you to the most grueling Pilates class ever, and they took you from pre-contemplation to action, and you know how that turns out. So you get angry at the person, you won't go back, you don't trust them, you feel like you were pushed, you feel like they did something that was out of your comfort zone and you resented it. It's the same thing. I'm giving you this example, but it's an example that you can relate to. It's an example that you can hang on to, and it's real. Because when we try to leap over stages and push somebody or catapult somebody into an area where they're not ready, then we get resistance, non-adherence, and relapse from individuals. So for anybody in this room that's interested in stages of behavior change, especially the trans-theoretical model of change, I want you to know that there are strategies that are linked to every stage. And that's the right side of the grid. What are the potential strategies for this individual? So my decision is this: where is this individual? What strategy should I use to most effectively work with the individual? Because I want to bring this person through a change process that is step-by-step, process-driven, and setting up the likelihood of good adherence and good consistency. And that's what the trans-theoretical model will do. And once again, I just want to remind you that just because you're in one phase does not mean necessarily that you're going to stay there. So just to recap, pre-contemplation, initial stage, not intending to take action, not intending to do anything. And these are individuals that we don't judge, we don't get critical, because many times a person's not taking action because they feel like they lack the skill, or they feel demoralized, they feel suppressed as a result of having tried to do something before. So I've tried to lose weight before and it didn't work. Or I lost it, but then I regained it and the person's demoralized. I tried to quit smoking and it lasted for a week and then I went back to it. So a person can be in the pre-contemplation stage because they feel like they lack the capability. They might lack the skill, or they may feel suppressed and demoralized as a result of prior attempts to change something. So once again, the standard, I look at these issues like an anthropologist. It's like, I look at it with curiosity. I don't enter it with judgment. I don't enter these situations with criticism at all. It's all, for me, a curiosity. And it's something that I'm going to learn, understand, and support a person to do and to guide them through a process. And this is just a restatement of the pre-contemplation stage. It's the elephant in the room, the topic that's not being discussed, and the support. And I just pulled this from the grid in terms of strategy. You want to increase awareness for change, personalize information about risks and benefits of change as well. So once again, the purpose of today's lecture is to give you a kind of a primer on critical decisions. And I'm pulling in, case studies, whether it have to do with anorexia, depression, for example. I'm just trying to connect things to real circumstances that are understandable to you. Okay, to summarize so far, we've talked about minimum clinical data set. What are our outcomes? What's the beacon? What's the light? What's the guide? Really important to understand. What are the cultural considerations? How do I modify my treatment based on the unique cultural circumstances this person is bringing to me? What about the issue on readiness for change? Is this person, or quite frankly, is this organization ready for change? A lot of my work is in the area of organizational behavior management. I do interventions at that level. And I ask myself the question, and I have to decide, what is this organization's real interest in change, and why are they interested, and what is their level of preparedness to make something happen? So that's where we've been so far. I told you at the very beginning, I got 5 decision points for you, and I'm going to cover the last couple in the remaining 20 minutes that I have with you. Decision number 4 has to do with what's referred to as multifactorial cause. That simply implies that there are many reasons why a person may be presenting clinically in such a particular way. And then there's a need for interdisciplinary collaboration with respect to this. For the purpose of convenience, I'm going to go back to anorexia nervosa. The etiology of anorexia is largely unknown, but what is understood is that there's multiple factors, which includes the person's neurobiology, their genetics, and there's environmental contributions that will maintain the eating disorder, and there's also cultural factors as well. Okay, so now I need to understand, this is my decision. I've got a person in front of me. Person has a diagnosis of anorexia nervosa, coming from the Diagnostic and Statistical Manual, 5th edition. The person has the diagnosis. I need to begin treating them. The first thing I have to decide is this: is there a genetic link? The reason I need to know that is because an individual with a genetic link is tenfold greater in likelihood to develop anorexia. And if the person has a genetic link, then it's also the case that the person has in their life faulty models. That means people that they live with. You know, it could be caregivers, for example, with an eating disorder like anorexia. They are presenting to the individual on a consistent basis faulty models in terms of interactions with food. This is the parent that is hypercritical of an adolescent or young adult in terms of things that they're eating. And it doesn't even have to be vocal verbal in nature, does it? How many of you in this room have sat across from another individual and they're looking at you during a meal, they're looking at your plate, and it seems like they're studying every bite of food that you take. And it raises a level of self-consciousness and awkwardness and a discomfort for you. And that could be the implication of living with a caregiver, for example, or another individual who has an eating disorder, and they are subjecting you to similar standards and subjecting you to a level of scrutiny and observation that becomes enormously uncomfortable. That's the implication of understanding this. The other implication from an early intervention standpoint is if I know there's a genetic link, then I can do early intervention with an individual. If an adolescent comes to me or a young adult and there's emerging signs of an eating disorder, and I know that there's a genetic linkage, then I can begin doing things with that individual from an early intervention standpoint. That is far preferred than working with an individual that is years and years deep into an eating disorder or any other type of pattern of behavior, because it's more difficult to interrupt and intervene when something is so well established. So understanding genetic links. And I do this during clinical interviews. This is how I acquire my information. You know, it doesn't matter if I'm talking about an eating disorder or somebody with bipolar disorder or a person with Alzheimer's, for example. I'll ask the question, you know, is there history? Is there something I should know? Something medically I should know? Or from a psychiatric standpoint, something you want to make me aware of that I should be understanding about your family circumstances? Very helpful. The other decision I have to make and what I need to understand, and again, I'm just using something like anorexia as a placeholder just for the convenience of our conversation today. Why is control over food and body weight so valued by an individual? Now, the decision I have to make is whether or not the person's patterns of behavior are resembling an addiction. Because if my answer is yes, there's an addictive element to what is occurring in terms of withholding food or refraining from eating or engaged in the use of diuretics, you know, urine producing and bowel moving interventions, or the person is using antidepressants, for example, one of the questions I have is whether or not there's an addictive element to this. Some good research on this, whether or not anorexia resembles addiction. Here is why. If it's addictive in nature, if the withholding of food, engagement in the use of diuretics, the use of antidepressants, the use of excessive exercise, or engagement in self-induced vomiting, purging, the person can activate the parts of the brain called the reward center of the brain, which includes the nucleus accumbens and the VTA section of the brain. These are your dopamine pathways. When they're activated, the individual is stimulated by this activity, likely to return to the activity and establish in patterns of the activity, which then enters into the category of addiction for an individual. So an individual with anorexia can develop an addiction for the withholding. Why do I bring that to your attention? It's because of this. One decision I need to make clinically is whether or not I'm considering the addictive aspects of this disorder, and whether I want to engage in some kind of interdisciplinary collaboration with another individual with also expertise in addiction to begin devising and developing the most appropriate treatment plan for this person in front of me. So I need to summarize. I'd like to know whether there's a genetic link. Why? Because the person could be living with faulty models. They could be subjected to ongoing scrutiny. Do I want to know whether or not the individual is entering into an addiction of some kind? I do want to know that because a pattern of behavior could be treated in such a way that resembles the treatment for addiction. So the reward center of the brain refers to structures that are activated by reinforcing stimuli, and the reinforcing stimuli in this case are the withholding of food, use of diuretics, use of antidepressants, use of excessive exercise as well. And it's activating the dopamine pathways. So now you've got a neurobiological factor. So we could have a genetic factor. We could have a neurobiological factor as well that's in play at this point. The other piece that I have to decide is whether or not the individual has a co-occurring anxiety disorder. The reason I need to know this is because 83% of individuals with anorexia also have a co-occurring anxiety disorder. So the individual could be suffering from anxiety, which must be addressed at the same time I'm addressing the individual's anorexia. As I mentioned, 83% of individuals will present with anxiety, and I can't not treat the anxiety at the same time I'm treating the individual's co-occurring condition, which is anorexia nervosa. So once again, we got genetic considerations, we got neurobiological considerations, and we got co-occurring conditions as well. And once again, as I promised you, I'd link it right back to the literature. And here's an article on anorexia and generalized anxiety disorder and the relationship between the two. So once again, I just like to make sure that I'm connecting people to the relevant literature at all times. And just for your information, for a person with an anxiety disorder and anorexia, that the withholding does become very rewarding to them because it allows them to modulate and control their anxiety. It gives them a sense of control over their life circumstances and control over the body as well. So these are decisions I need to make in terms of whether or not something like that is in place. Finally, I need to understand whether there's adverse events or a trauma history with an individual. So people with eating disorders, for example, have histories of sexual abuse, physical abuse as well. And specifically, and I've got it highlighted right here on your screen, about 30% of individuals with eating disorders have been sexually abused in childhood, and most of them suffer from bulimia nervosa or binge eating disorder. So my summary point so far, to understand genetics, understand the neurobiological aspects of what you're treating, understand whether or not there's factors at play, such as a trauma history, that may be influencing. And I bring all of this to your attention because treatment and intervention will be not comprehensive, not fully addressing the root cause of a problem unless you're taking all these factors into consideration. And that is what we want to do from a psychological intervention standpoint, is to understand root cause. What is the driver? Is this addiction? Is this because of a genetic linkage? Is this because of a trauma history, an abuse history? Is this because of a cultural factor and consideration? Root cause. It's only through root cause analysis are you able to devise, develop the most comprehensive, humanistic, and thoughtful interventions for an individual. And just for your information, when there is a trauma history, the individual's impact, it's what's referred to as a sequelae of an event like trauma. There will be neurobiological impacts, emotional impacts, and cognitive impacts as well. So an individual with a trauma history will have difficulty mediating and modulating arousal states. So this is an individual that gets pushed into a rage state and you cannot get them back. You cannot get them returning from their anger, and it could take hours. Somebody in this room knows another individual, or again, could be you yourself, that moves into an anger state and stays there for hours, days, or even weeks. This can be linked to trauma histories as well, because one of the impacts that we have, and we know, is that an individual's frontal cortex is impacted, and that is where you have capability in terms of mediating your arousal state. Your executive functioning skills are also compromised. Your ability to think through, problem solve, do critical thinking is also compromised as a result of trauma histories. Your behavioral regulation and your memory is also impacted. So this is why we want to know these things, is that if there's a trauma history, then I've got an individual who may be compromised from a thinking standpoint. Have you ever wondered, and I'll take it out of the realm of trauma right now and bring it to alcoholism or substance abuse. Have you ever wondered why, despite, the clear evidence that a person needs to stop drinking, or despite the good guidance that the individual's received, that they keep defaulting to the same patterns? One of the things that you may not be considering is that the person's cognitive capability, their executive function skills, their ability to control impulsivity has been so severely impacted by persistent alcohol use or drug use, or impacted in a serious way as a result of repetitious trauma to the individual. So what I'm trying to accomplish here is to broaden your thinking. And I don't want to make assumptions that you're not already thinking like this coming into this room. I won't make that assumption. If you think this way already, then I'm hoping that I'm just validating you. But these are things that have to be decided and thought about and thought through when treating an individual. The reason is because, and this is a great article on behavioral phenotypes, the treatment that you identify, and this is the next thing. I told you one thing I really want you to remember coming out of this lecture. This is the second one, that there are many times particular behavioral phenotypes that call for very specific interventions. That interventions cannot be generic in nature. Many times they have to be prescriptive based on the person's behavioral phenotype and what you're managing. And that can be a phenotype that's associated with an eating disorder, for example. Okay, I got about 5 minutes left, and I think I'm right on time. And I will leave room for questions. And it leads me to decision number 5, and that is, what evidence-based practices am I going to use? Evidence-based practices meaning those interventions that have been implemented and controlled as a result of randomized controlled trials or single subject experimental design, but as a result of the study of these interventions and an analysis of the results. These are the interventions that are proven to be supportive and effective for individuals. So now my decision is this: what intervention should I use for this person? And that always comes down to me as a question about goodness of fit. Is this person going to benefit most from enhanced cognitive behavioral therapy if they're anorexic, or family-based treatment, or dialectical behavior therapy? Or maybe it could be a combination of something like family-based treatment and enhanced cognitive behavior therapy. It could be a permutation that I use, but it's an important decision. And for me, I will often, well, not often, but always get the input of the person that'll be receiving treatment to give me their opinion about what is best for their life circumstances. This is the cognitive behavior therapy expanded model. It's a stage-based model that's used for treatment. I like it because it aligns with the trans-theoretical model. You'll notice in stage 1, you're just starting off with just discussion about starting off on a good foot, starting off what they refer to as starting well, and then doing some reflection. So now the person's in contemplation mode, right? With stage 2. And then stage 3, you got dietary restraint. And then you're doing an evaluation of events, moods, and your eating behavior. So now you're in an action stage. So you can see how it maps on to the trans-theoretical model as well. And then finally, all of these decisions that I've told you about in the last hour and 15 minutes, my work is largely in technology. And one of the things I design is what's referred to as decision models, because my interest is in teaching clinicians and giving them the tools to think through something step by step. And the way I do that is by designing a decision model that will allow them to walk through a clinical problem step by step and identify the appropriate assessment tools, consider the cultural factors, identify the appropriate minimum clinical data set that'll be used for evaluation, consider the multifactorial elements. Is there genetic issues? Is there addiction? Is there some neurobiological aspect that I need to be aware of? And then it leads me to my evidence-based practices. And even with the evidence-based practices, it gives you a step-by-step guide to implement it. And this is what's referred to as a clinical decision support system. It's a technology-enabled system. This is an article I published probably a couple of years ago on the use of clinical decision models for things like pediatric pain management, for example. So those are the 5 decisions, and they're important decisions for all of us from a clinical standpoint. And they include the identification of minimum clinical data set, cultural factors, and then genetics, neurobiology, culture, as I mentioned, the evidence-based practices that I could use, and the guidance that's necessary for good clinical intervention. I think I am right on time, and I thank you so much for your kind attention for the last hour and 15 minutes. I hope the information was either validating or informing, or maybe a little bit of both. And now I just turn it over and open the group for the opportunity for questions.
Подскажите, пожалуйста, распространено ли среди психологов и психотерапевтов просить своих клиентов проверить кровь на наличие анемии или дефицита витаминов, например, витамина D?
The smart ones do. And I don't say that with humor, actually. But especially those people trained in the area of behavioral medicine, they'll look at blood panels, specifically nutritional blood panels, for example, because a lot of behavior can be driven as a result of deficiencies that a person has, and their functioning is compromised because of these deficiencies. So blood work, specifically taken the form of a nutritional blood panel, will inform the psychologist in terms of the best direction. Because when we talk about multifactorial treatment, then that individual whose blood panel is shown, nutritional blood panel, is showing deficits, critical deficits in vitamins, nutrients, for example, part of the intervention, not all of it, but part of it is definitely going to be dietary in nature and getting that person to a health condition that's conducive to that person's overall therapeutic process. So the smart ones will do it. The smart ones will also look at things like stress hormones, cortisol levels in the body. I measure cortisol by way of saliva swabs, urine tests, and blood tests, because if I'm dealing with somebody and addressing a stress condition or an anxiety condition, then my progress can show up as a result of the stress hormone cortisol, and that will be measured. So my answer to the person that posed the question, yes, the smart ones will do it. Certainly not everybody does it. But if you really want to be informed, then nutritional blood panels and other blood tests can give you very important information that will guide your therapeutic process.
Кроме когнитивно-поведенческой терапии, какие техники, на ваш взгляд, более эффективны?
A lot of my time is spent in the area of acceptance and commitment training, also referred to as ACT training. There's a growing body of literature on ACT-based interventions, again, acceptance and commitment training, interventions for multiple clinical presentations. It's been used for depression, it's been used for obesity, it's been used for substance use and abuse, it's been used for eating disorders. So currently a lot of my research is in the area of ACT. I just recently published a paper on using ACT-based interventions for promoting exercise and exercise adherence. I've also used ACT-based interventions for working with families with children with autism spectrum disorder. So my answer to the question, to the person that posed the question, is acceptance and commitment training is an area that is a strong focus for me, in addition to cognitive behavior therapy as well.
Подскажите, а если рекомендуется принятие лекарств нашему клиенту, это получается уже не психология, это рекомендации уже для работы междисциплинарной команды?
That's exactly right. That's what's referred to as coordination of care. And in fact, the meeting that I came from right before coming into the room with all of you was with a psychiatrist for exactly this reason. that the person requires an adjustment, in this case, in their medication. So it's not me that does the prescription as a psychologist. It's a psychiatrist that that's a medical doctor that is going to prescribe those medications. Now, here in the United States, there is a credential that a psychologist can receive to give them the rights and the ability to prescribe. But it's a very low percentage of psychologists in the US that do that, but it is possible. But more often than not, we're working with a physician, it could be a pediatrician, or it could be a psychiatrist. And you're correct. We do things as a team. It's what's referred to as coordination of care collaboration. And we need it because, again, many of the answers in terms of appropriate treatment involve multiple methods, not just one method, many methods. And oftentimes it's a medication intervention in addition to other things happening from an intervention standpoint that's necessary.
Можете, пожалуйста, порекомендовать какую-то базовую литературу по данной тематике?
Specifically on coordination of care, collaboration. Yeah.
По данной теме. Да-да-да, расстройство пищевого поведения.
Oh, eating disorders. Yes. I've already sent over some many articles on eating disorder because I anticipated this coming up as a question. But if anybody wants more than what I've already sent, just say the word, and I'll certainly pull more literature for you.
Мультифакторная каузация подразумевает те 4 пункта, о которых вы говорили. Может быть, есть и другие аспекты, помимо генетики, травматичных событий, которым также следует уделять внимание в работе?
Culture, environmental considerations and cultural considerations. So it comes down to genetics, neurobiology, the person's environmental circumstances, and the person's cultural circumstances as well. And then many times trauma histories.
Меняется ли ваша практика в зависимости от того, принимает ли пациент препараты или нет?
The medication piece informs my practice because one of the things I'll put in place is what's referred to as the medication side effect scale. It's also referred to as the MOSES, M-O-S-E-S, the MOSES scale. So my practice will change because I will include the side effects scale and I'll evaluate that individual for side effects. And side effects can fall into many categories. There can be issues with gastrointestinal problems. There can be issues with the person's endocrine system and even their sexuality, and their sexual urges can get muted or suppressed as a result of medication usage. So the answer is yes, because I will include a medication side effect scale, but I'll also include measures based on what the medication was used for. So for example, if it's an antipsychotic, something like the medication risperidone, then that medication will be used for reducing rage and anger states in an individual. So for that reason, I'll have measures in place and tools that I use to evaluate rage and anger And that will be because the person's medication should be addressing it, and I want to quantify the impact. So the answer is yes. It'll be inclusive of medication side effect scale, the MOSES, MOSES, and will also include evaluations of the impact of the medication, the favorable impact of the medication. So is a person's rage actually reducing? Is their anger actually being reduced? Are they more capable of self-control and refraining from impulsivity? So yes.
Есть ли особенности в прохождении стадии терапии, когда пациент возвращается на первый этап работы с проблемой после рецидива? Как грамотно не дать человеку сойти с пути решения?
Yeah, this is you know, when I agreed to do this presentation, I was told that the questions would be good and that there's a high curiosity, and that is so accurate because I'm finding the questions to be really good and the curiosity to be refreshing. One of the things I do, I'm just going to use an example of obesity, because I've worked with a lot of individuals with adult obesity, excess body weight. During my process, because I know these stages, and I think this is why the audience member is asking the question, because we know we can go from one stage and lapse back into an earlier stage. As I'm going through my treatment with an individual, I keep a running record. It's what's referred to as a self-control inventory or self-knowledge inventory. As a person's going through treatment and is responding well to treatment, I have them document exactly what it is that's working for them. So for example, for a person with a weight control issue, you know, maybe they really started making progress when they started monitoring their calorie intake. You know, maybe they used one of the popular apps. I'm sure they're available in Russia as well. Could be MyFitnessPal, or it could be Noom. It could be any number of devices. But if they were successful using that and they started getting and making some progress as a result of the use, and they started doing some other things as well that were effective, I will have them document it in a self-knowledge inventory tool. And I typically do that on an Excel file. Here's why I do it. Once that person relapses, and many people will, it doesn't matter what we're trying to treat, whether it be an eating disorder or a person who just overeats and has excess body weight, if they relapse, then I bring them to their own self-generated file that describes what was effective for them. And I get them to return to those earlier steps because it was their experience, because it was their success, and it was not something disconnected from their circumstances, but directly connected to their personal circumstances. So to answer your question, I maintain a running record of what's referred to as a self-control inventory or self-knowledge inventory, documenting every effective strategy, because I know that if the person relapses, then I can bring them back to their own writing and their own notes, and that is going to be the most powerful tool I can use for getting them to recover.
У нас остается два последних вопроса, и на этом мы будем завершать процесс. Подскажите, есть ли особенности в прохождении стадии терапии, прошу прощения, возможно ли работа с подростком, если он не мотивирован на эту работу, его привели родители? Если да, то какие ваши рекомендации?
Yeah, I'm glad I reviewed the stages, the behavior change stages, because an adolescent that's not motivated is in the pre-contemplation stage. they may not even be acknowledging that there's any issue, that it's just the parent's problem, not their problem. It's not their issue at all. Is it possible to work with them? Yes. But this is why you need to pinpoint, identify exactly where they are. If they're in the pre-contemplation stage, then the strategy and the intervention has to be aligned with the pre-contemplation stage, meaning that you're in an educational mode with them. Many times it's perspective taking. That's what I do with that type of individual. You know, can you imagine, can you put yourself in the shoes of this other person and talk about what they may be experiencing? So it is strictly educational. I'm so glad that I did these stages of change models, especially the trans-theoretical model, because the answer is yes, but you've got to match your intervention to where that person is in their change process, whether it be pre-contemplation, contemplation, or action, or maintenance. It's important to identify that.
Считаете ли вы определенную регулярность терапевтических сессий необходимым условием успеха терапии?
I'll tell you, my experience is that they do not have to be regular. I always, if it gets too infrequent to be therapeutically beneficial, then I'll tell the client. However, I have had success where a person determines their schedule of sessions, and for that not to be determined by me. Here's why. It gives them a sense of control over that. And I think everybody in this room has probably experienced somebody sitting in front of you that sure the heck did not want to be there. So when that's the case, you know, I go into what's referred to as choice making. There's a nice body of literature on what's referred to as locus of control or location of control, and giving a patient an opportunity to control their circumstances can result in improved outcomes. So the decision to do it is individual. It's based on who the person is and how frequently, you know, they're engaged. But I have used that strategy, and I have been successful with the strategy.
И остается последний вопрос. Подскажите, как отличить небредовую дисморфофобию, при которой человек недоволен патологически своей внешностью, ищет дефекты, от бредовой при расстройстве пищевого поведения?
Yeah, this is where the addiction piece comes in as well. A person can have a thought process that is so recurrent and so ingrained that it doesn't matter what you do, what you say, the person has persistence with the thinking, especially for a person with an eating disorder. They move into a place of malnutrition and many times dehydration, which then compromises their executive functioning skill. So you end up talking to an individual that does not have their full capability from a thinking standpoint or an intellectual standpoint. This is why, if you remember that statistic that I showed you earlier, 10 to 20% remain chronically ill, is because they've been so impacted from a neurological standpoint and a cognitive standpoint that you can't make progress with them. This is especially true with eating disorders. But at least leaving this room, I want you to understand, you know, why that may be happening. It's not necessarily because the person is stubborn or because they just refuse to see things in any other way. They may be physically and cognitively incapable of shifting. And this is what's referred to as cognitive rigidity. The person is fixated and rigid in a way that makes them unworkable. And that's why 10 to 20% of people with eating disorders will not recover, is because of the cognitive rigidity that they have. It's also why I use ACT-based intervention, because acceptance and commitment training is designed to promote cognitive flexibility as opposed to rigidity.
Майкл, спасибо вам огромное. Время занятия пролетело очень быстро. В чате огромное количество благодарности вам за сегодняшнее занятие, которое было очень интересным, познавательным. Спасибо большое за ваши содержательные, развернутые ответы на вопросы и за то, какую структурную систему вы помогли выстроить в контексте заявленной тематики. Спасибо вам огромное. На этом мы вас отпускаем. Спасибо большое, что
You're
открыли.
very welcome. I'm so impressed with what all of you are doing with inviting people internationally. Bye, everyone.
Спасибо большое всем участникам сегодняшней встречи. Спасибо за ваши вопросы. Действительно, очень интересно было наблюдать за тем, как вы ловили информацию, которую Майкл сегодня презентовал. Сегодняшняя наша встреча завершается, но на следующей неделе, во вторник, у нас будет сразу два спикера из Кембриджского университета. Мы с вами обсудим тему правды и лжи в воспоминаниях, поговорим о автобиографической памяти. И очень рекомендую подключаться, потому что действительно тема максимально прикладная, касается не только нас самих, потому что все мы как субъекты психики обладаем и памятью, и автобиографической памятью в том числе, но и потому что в том числе, когда мы говорим о работе с клиентами, мы в рамках консультативного процесса можем говорить о работе именно с автобиографической памятью. Поэтому тема лжи и правды в воспоминаниях является особенно актуальной в контексте прикладной психологии. На этом мы с вами прощаемся. До встречи в следующий вторник. Всего хорошего.